My blood pressure is 117 over about 70, which I thought I was cool. But my resting heart rate is about 80. I don't think that's so great. And one more thing, for a 60-year-old man who is doing okay, do you think a CT scan of the heart is a good idea? Plant-based 60-year-old man?
So that's a whole bunch of questions, actually, that everybody's going to want to know. Okay. So is 117 good? Absolutely. Is the heart rate of 80? Yeah, you know, everyone would like to have that heart rate of 45. Actually, he's got it. Okay. Looks like you're off the hook. Okay. And so people are concerned about the heart rate of 80. It'd be nice to know what your heart rate variability is, whether or not you're having extra beats. I know most people are familiar with the fact that the watches now will do heart rates for you and give you an average heart rate. Everyone would like to have that marathoner heart rate of 45, but it's really not necessary. And when do you start to get concerned about the heart rate? Is if it's more than 100. So 80 isn't that bad. It might be an indicator, depending on how much exercise you're doing, that you're doing more isometric and resistance exercise than you are endurance exercise. The endurance athletes are the ones who tend to have the much lower heart rates. So I wouldn't be so concerned about that. So then the issue of CT scanning, all right? It is one of the favored tests that is completely underutilized. It's typically not paid for by insurance, okay? But the coronary calcium score is incredibly predictive. And I didn't go into it in here, but we actually do use it for prevention. That coronary calcium score, you can sort of use that as a risk predictor. It is more accurate than just adding up risk factors and putting them in the little app, okay? And it's inexpensive. Most places have it for $49. Rush University is $95, and you end up paying out of pocket. But at the end of it, you do get a score. So who should have it? That's where people will differ. And I would say that if you're concerned that you have disease, and that's where it comes into our guidelines. If you're concerned that you should be treated or having more diagnostic tests, like a stress test or the like, that's when it's really a good idea to do it, if you have risk factors. And if you say American person, male, over 60, that is actually quite reasonable. Okay.
Hi. Thank you.
Oh, hi.
Thanks for the wonderful report you gave us. It was very helpful. I have a question for you. I've been on high blood pressure medication for Nevapril for 18 years, and all of a sudden my blood pressure has started to rise to 150, 160, over 91, over 80. But you did mention something in reference to apnea.
Sleep apnea?
Yes. Mm-hmm. And so, how do you treat? Well, I'm thinking that perhaps my blood pressure went up because of the sleep apnea, because I have been diagnosed with that. So I thought maybe that's the reason for it. But does that mean that they treat it with heart medications, or could it be that the heart pressure, my blood pressure has gone up because of the apnea?
So if I try to...
Because I'm already on medication.
I'm going to go with the principles because we're not supposed to do a doctor-patient
thing.
Okay, so remove the my part and just talk about sleep apnea. It's really important.
And how you treat it.
It's an issue that's on the rise because of our obesity epidemic. Okay, you're not you personally, but there are people who are non-obese who have it as well. And the best way to try to realize that is to have someone tell you that you're doing a lot of snoring, okay? Having daytime sleepiness is another one, and then high blood pressure as well as rhythm disturbances. So if these are all very important signs that you may be struggling with that particular condition. Now, what do you do about it? Most important thing is to do a sleep study. That is a technology that's dramatically changing. At the last heart meeting, tell me where this is February, so that was the American Heart Association. There was a company who had a device that you just take home and you hook yourself up, and then it tells you everything. It tells you what happened to your heart rate, it tells you what happened to your blood pressure, what happened to your oxygen level, and it gives you the decibels of how loud you snore, okay, at different times. It was, and how often there's no air exchange. So that's completely different than what we've been doing in the past with the sleep centers, and everybody has to sort of disrupt their life and go and sleep in this lab, what they don't feel comfortable sleeping in. So we've really got new techniques. Now the question is, what do you do about it once you find out that you've got a high number of decibels and you're snoring really badly, and then you stop breathing because you're completely obstructed? That's changing as well. So it used to be just that big CPAP, continuous positive airway pressure mask, and you would titrate it. Do you need 5 centimeters of water? Do you need 10 centimeters? What do you need to keep your airway open? And how do you sleep with this thing on? And my patients, I'm not a pulmonologist. I don't treat people, but interacts with cardiology a lot. And I can tell you that I got 50-50 in our patients. People get CPAP and they say, I absolutely can't stand it. I can't sleep with it. I'll never do it. I'd rather die. And other people say, oh my gosh, that's the best sleep I've ever had in my life. And so for this side of people who really don't like it, there are new masks, there are mouth guards, there are all sorts of new devices that people are working on to try to get people much more comfortable, better fits and better equipment. And so I'm glad to see that technology take off. Bottom line would be, I started to say for you, but we're not doing a you. Okay, so the best thing to do is to find a local sleep specialist, okay? And we certainly have them at Rush University if you want to fly over to Chicago. Right, so you might want to consider making sure that it's working. And if you're not having the problem with sleep apnea, then it's not contributing to your blood pressure anymore. Okay. So you got 2 people standing in line there, but then we got 5 people with their hands raised. So I don't know. Okay. Okay. So were you in line, sir? No, you weren't? Okay. Oh, so the question up here was principles of long life. Okay, that is, so I kind of tease people. Everybody asks me, because I'm in a lot of nutrition conferences, what should I be eating? I say, I don't know. All I know is what not to eat. Okay. And so I would say stick to cardiology. That's first of all, cardiovascular stuff, and it really would be, if I had to pick out the things to do, it'd be exactly the hypertension talk that I gave. So you're probably wondering, why am I even going to try to answer that question? It's so off topic. It's not off topic, because I think all of the principles were actually on that lifestyle slide, okay? That is lowering sodium in your diet, increasing the potassium in your diet, exercising with the multiple modalities. Where do we do it? At least 150 minutes per week. If you're normal, if you are treating anything, more than 300 minutes a week, doing completely plant-based diet. If you had to do low-fat dairy, they'll be better off than you would with an American diet, and drinking less alcohol and losing weight. If people are ideal body weight, exercising daily, plant-based nutrition, that's going to give you your best life. Now, I mean, I'm sure you've heard real experts, but I can tell you what I've learned sitting in these conferences. There are other things like being happily married, not just married, but happily married, having a pet. If I had to pick the one with the biggest numerical change, it's tennis. Okay, 42% decrease. It's a British Medical Journal about 8 months ago. Racket sports in general, but tennis specifically, lowers your mortality. So happiness and long life, so be surrounded by love and play a lot of tennis. Plant-based nutrition.
Question. I have heard that blood pressure medications work better if taken at night. And if that's the case, do they stay in your body for 24 hours?
Yeah, so now you're really going to get me going. So the issue is, when do you do the blood pressure therapy? Do you do morning or evening? a lot of the nighttime taking the blood pressure pills before you go to bed, there is small amounts of data that say that improves the outcomes. I'm much more concerned, however, about physicians not knowing how long the drug lasts. Let me just take one class and give you one example. That would be the angiotensin receptor blockers. They end in sartan. So there's telmisartan, there's losartan. Valsartan became famous recently because there was poison in it, and hopefully everyone heard about the recall of valsartan. Then you found out that it was in losartan and irbesartan. Don't worry, there's 8 of them on the market, okay? So 3 of them going bad, not to worry. But my big concern is that people don't know how long those drugs last. So it turns out that losartan is the #1 drug, it's the least expensive, and it has a half-life of 2 hours, and you take it once a day? Now, if you take it once a day, how long would you like it to last? Maybe 24 hours? And that would be telmisartan. And the problem with telmisartan is it's a little more expensive. Why? Because it's got the best outcome study, so the generic people charge more for it, and a lot of insurance companies don't want to pay for it. So bottom line is, if that's just one example from one class of drugs, what I would encourage everybody to do is just go on their search engine and take the drug that they're taking, okay, particularly if it's once a day, and say the name of that drug, like losartan, half-life. And if it's something that's short, make sure that your blood pressure is controlled right before you take it. So that would be sort of the lowest level that it's ever going to be is right before you take your next pill. And if your blood pressure is controlled, then don't worry about what I'm saying, okay? If the blood pressure is not controlled, so what am I really saying? Is that whole thing that we do, having the patients get up in the morning, take their blood pressure, medication, drive to the clinic, sit in the office waiting for me for an hour, okay? All right? And so I'm about 2 hours after they've taken their drug, and then I measure their blood pressure. Well, that's putting the best foot forward for that drug, but it may not be best for the patient. Because what happens after that? Late evening, after they get into an argument with the boss in the office, you really want to know the blood pressure all over and have drugs that are going to last a long time. So thanks for that question.
My question is, a person who has high blood pressure, they have done all the lifestyle changes, and it's recommended by their doctor that they go on some type of blood pressure medication. How can a person feel comfortable going on these medications? There have been so many recalls.
So, well, if you look at, first of all, the entire breadth of cardiovascular medicine, the number of recalls has been very few. So 2018, the valsartan, the irbesartan, losartan. The other one was Lipitor in November of 2012, where somebody put glass in the 20 and 40 milligrams. But there really aren't a lot of drug recalls in cardiovascular medicine. And these are drugs that have dramatic improvement in outcomes. And you saw it in the SPRINT trial. You treat people, what was the difference, by the way, between the 140 group and the 120 group? It was essentially 0.9 more drugs, okay? So an average of 3 drugs versus 2 drugs. And really made a difference. If you're talking about not just lives, we're talking about brains. And so being able to save events means that people should be taking their medications and don't be afraid of them, but stay abreast of what's going on. None of this stuff happens, in a closet. You're seeing, you get news reports, just pay attention. And if everybody's, listening to their doctors and sometimes informing their doctors, you won't be taking a drug that has a recall. My real answer would be, it would be great if we had a system that was so electronic that the moment there was a recall of your drug, you instantly got an email. And I bet we get there because we have e-prescribing. It's not that hard to make that happen. There's a lady, I don't know who has the microphone, but there's a lady who's in the back, and I'm so concerned that her arm is going to become ischemic. So, okay.
Hello, thank you for your concern. I was just stretching. No, these sonars are amazing. I don't want to get out of them. They're really, really good. My mother has fluctuating blood pressure, and she is on blood pressure medication. She's changed to a whole food plant-based diet with still about 3 eggs per week. And I know what you have to say about eggs. I say the same to her, but I can't get her off the eggs. She has now dizziness, and she's afraid of falling very often, and her blood pressure fluctuates pretty much. Could that have something to do that she has dizziness?
Okay, so let's go back to the conversation we were having about treating blood pressure in the elderly populations. Really important. So first of all, that what we call labile hypertension, where the blood pressure is fluctuating a lot, that can be extremely vexing. And we think we've got control over it. Oh, if they don't drink coffee, or if nobody upsets them, or if they don't have a big sodium load the night before. You think you can get control of all the factors, and it's still going to be highly variable. That does happen. And so what you must do, first of all, is try to make sure that the blood pressure is not too low in the standing position. So you do a sitting and a standing. And then the next question is the feeling of dizziness even related to the blood pressure? And it can be because of the blood pressure dropping suddenly, okay? But it also could be because of problems in the so-called posterior circulation, where you actually need to look, so-called lacunar infarcts that happen with high blood pressure. And so it actually is a manifestation of damage to the brain. And so sometimes you need just a standing blood pressure. Sometimes you need a neurologic evaluation, including an MRI, to try to figure out whether that's what's going on. Okay.
Hi, Dr. Williams.
Hi.
Thank you so much for taking time out of your busy schedule to be here today. I just wanted to ask you about low blood pressure. I've suffered from that. Whenever I go to get my blood pressure taken, everybody takes it 4 or 5 times. They'll, asking me if I'm dizzy. I say no, and then they say okay. And I'm wondering if there's any concern or issues that come along with that.
So, I guess the biggest advice I would give to someone with low blood pressure is to rearrange your retirement funds, because you're going to live a long time. Okay? Okay? So, yeah, I used to, I never worried too much about it until it happened to me. I mean, so African American, of course, when I started medical school, blood pressure 140, read in the physiology book about sodium, cut the sodium, went to 128, thought I was doing good, went vegan, 104. And sometimes, that's right. And, sometimes, you take a blood pressure and it's 104, and then it's 98, and you worry a little bit, and then you stand up and, you're not dizzy. So you're not dizzy. That's the important thing. So that's really a great thing. Keep the blood pressure low. Keep doing all the things that you're doing, and hopefully, what do we really worry about? That you'd get a fever or some illness or something like that, and your blood pressure is going to go to 70, and they're going to start trying to, give you a whole bunch of medication. That could happen, but just probably the most important thing is just to inform the healthcare practitioner, which I'm sure you do. That's my normal blood pressure. Okay? All right, very good.
Hi. You didn't discuss water at all, and I know for some people, like especially elderly, they'll get dizzy from not being hydrated enough and their blood pressure being elevated. And then the second question is, there's not a lot of doctors who are open to a plant-based diet. They still think it's not going to make a big difference. So what do you suggest for people to be their own advocate with their doctors?
So the issue with water is that there just isn't a lot of data on it. You see a lot of healthcare providers who say you should be drinking like 2 quarts of water, and then you find nephrologists who say, oh my goodness, 2 quarts is fine, but if you go over that, you're going to wash out your, ready for this, renal medullary gradient, and you could end up with hyponatremia, low sodium, and so, or so-called water toxicity. So there isn't a lot of relationship between blood pressure therapy and water consumption, one way or the other, to be able to make a class 1 anything recommendation. But dehydration is a problem. If a person's intake is very poor, that really is the issue, and I'd be worried not just about water, but about calorie intake, and because that is one of the manifestations of frailty in older people. And you know, I showed you the outcome. It didn't focus on it, but if you saw those event rates or the mortality rate or the survival rate in frail people, it was terrible. It was better if you treat their blood pressure, but it still was terrible. And so everything we can do, excuse me, to keep our older population active would be really, really helpful. So you had a second question, though. It was?
A lot of doctors still are not on board with
Oh, right.
plant-based diets.
Yeah, so I'm always talking about the leading cause of death of physicians and cardiologists being heart disease, and because nobody's aware of plant-based nutrition. Unfortunately, those numbers are being challenged now because of physician burnout and all the issues that are associated with that. But I would say the best thing to do, particularly in the hypertension area, is to refer them to our hypertension guideline. And they will see that table with the lifestyle changes and see that the numerically largest way of changing a patient's blood pressure without a drug is to just put them on that DASH diet or something that has a lot of fruits, vegetables, nuts, legumes. You do that, the patient's blood pressure is going to get better. Hi.
Oh.
Hi. I think she's...
Thank you. I worry about having a heart attack because it's all over my family. My blood pressure has been funny, so I'm monitoring. I'm doing Esselstyn for a few years. I'm mostly good. But my question is, for someone who wants to be able to have something between home and EMT or hospital, if something is suspicious, what is a substance that we can have to maybe take? Like, shall I continue carrying 2,000 milligrams of magnesium with me at all times? Is there cayenne pepper good? Something like that. That's my question, if that's part of your bailiwick.
Wow, so a little off the hypertension concept, but I would say that there's no magic bullet other than doing plant-based nutrition, knowing what your risk is, knowing what your cholesterol is. And if I had to pick one thing that's going to stop people from having heart attacks, it would be having an LDL cholesterol that's as low as possible. And so hopefully you know what that is, and if it's high, then it is of concern.
Well, mine is high, and I'm working on that. But anyway, my other question is, have we gotten away from cardio-CRP, lipoprotein, homocysteine on the predictive diagnostic tests?
Not exactly. Dealing with them one at a time. Homocysteine, maybe 15 years ago was a really big deal because of the recognition that there's like about 12 different ways where homocysteine messes up your blood vessels and promotes heart attack, stroke, and death. And there were 2 large randomized trials that got in the way. They were giving B12 and B6, lowered homocysteine levels dramatically and had no impact on cardiovascular or overall mortality. And there was a trend toward worsening. And so we sort of stopped measuring it, not because it's not important, but because there's nothing you can do about it. Now, is that one of the things that improves with plant-based nutrition? Absolutely. Okay, so then let's do CRP. So high-sensitivity C-reactive protein, popularized by my good buddy, Paul Ridker at Harvard. He's a very dynamic guy looking at inflammation, looking at treating it with multiple different ways. And every plant-based nutrition evaluation has shown that plant-based nutrition decreases inflammation. And C-reactive protein will decrease dramatically, and that may be one of the major mechanisms, along with the cholesterol reduction, at why you can decrease heart attack, stroke, and death. So we don't measure it a lot, mostly because it correlates very well, both in terms of statins, in terms of exercise, in terms of diet. All of them reduce both LDL cholesterol and C-reactive protein. And in fact, there was a large trial, the CANTOS trial, where a drug, canakinumab, that decreased the inflammation markers but didn't decrease LDL cholesterol, did not decrease, it did have an impact, but it was a much smaller impact than what folks were hoping. So treating inflammation by itself without the rest, improving in cholesterol, didn't seem to be quite as impactful.
Hi there.
Hi.
My question is regarding using, across the board with all pharmaceuticals, chronic long-term use leading to deficiencies, side effects. And can you speak a little bit, I know it's a protocol, you know, it's specialized for everybody, but any protocol in regards to weaning off medication? And when's the right time to do that if your health is in a good state?
So that actually was the topic, okay? So you saw what number was it, everybody? Where you would want to, where your target, where if you're below there, you could come off your medication?
Like 120,
130,
124.
130, okay? So still, yes, at 120 we're elevated, but we don't use drugs, okay, for it. So yeah, if you are able to start with your drugs, and sometimes having blood pressure treated for a long time softens up the blood vessels a little bit, improve kidney function, you actually may see a reduction in blood pressure that's sustainable without drugs. But it's usually those big lifestyle things that we talked about in the guidelines, okay? That once you do all of those, you get the blood pressure down and you start weaning off, cutting the drugs in half. It did happen to one of my patients who went vegan, so I always tell this story. Blood pressure was elevated. It took me about, almost 10 years to get him to go vegan. He did. Blood pressure had a dramatic fall. He wasn't monitoring them, as I always tell all my patients. And so he's feeling pretty bad. Went to his primary care doctor. I feel weak, dizzy, I don't feel like exercising. Measures the blood pressure, it's 80/50. And the doctor says, you have to eat meat so that you can take your Diovan HCT. Yeah, so the recognition that when you change any of these parameters that we're talking about and your lifestyle impacts your blood pressure, that you have to back off of the drugs and you're using 130 as the threshold. And so, yeah, there will be people. I say, if you looked at them, going back many, many slides to that Neil Barnard meta-analyses, you look at about 1/3 of those studies showed absolutely dramatic drops in blood pressure. Some of them were moderate, some of them were mild. But that 1/3 who had dramatic reductions in blood pressure, they have to come off their drugs, or else you're putting them in danger. So we're always monitoring, and how do we do it? Home blood pressures, okay, and using 130.
Dr. Williams, one question, that do you do pharmacological tests to see that which drugs suit the patients or no? Because some of the labs, they do offer, but it is not routinely done. Mm-hmm. So if the patient is put on losartan, amlodipine or whatever, but if it doesn't suit them, they can take that, the results to the doctor and tell them, is it a common practice?
Not common practice. So what happened to pharmacogenomics? Whatever happened to that? So about 10 years ago, we pretty much thought that we were going to be able to take a person's DNA and tell them which drug was going to be the best for them. Well, it turns out that in the larger studies, it doesn't seem to make as big a difference as we thought. And that applies to a lot of drugs, but you're hearing new and different things, such as cancer therapy. There are places that are doing, taking the cancer cells, doing them different kinds of treatment and coming up with exactly what the treatment could be. I don't know that we're ever going to get there with high blood pressure, just because there's so many different kinds of environmental factors. I mean, that table with the lifestyle changes, those are big deals. And a person has to be able to try to negotiate all of that. So it's not just genetics. There are some broad swaths that you can take away that are in the guidelines, such as people with African American heritage, okay, or self-identified African Americans, really should be on a diuretic, okay, because the change in blood pressure is much larger with that than, say, for example, with an ACE inhibitor or amlodipine, which they're great drugs, but the impact is going to be higher in different subsets of people. But that's really not genomics. Those are self-identified, ethnicities. And so I'm not sure that we're going to get there soon, but hopefully at some point we will.
And also the heavy metals, and because it is so important to look into the heavy metals and detoxicity, that everybody is detoxifying your system. Like in the back, they have this infrared sauna that without, you are not perspiring and removing your toxins. So could that be considered in the near future?
So again, we're looking for hard evidence, prospective randomized trials. The best therapy for heavy metals that's been out there is chelation therapy. And there was the TACT-1, and hopefully the TACT-2 trial will be published soon. These were attempts to do EDTA infusions to get all the heavy metals and try to get calcium out of coronaries. And the improvement in outcomes was minuscule and really not the kind of improvement in outcome that you would get, for example, with a statin or aspirin. Not even close. And so, we don't have if I had to pick one heavy metal to avoid, it probably would be, getting people off of seafood that has mercury, okay, because that does increase blood pressure. The other one that increases blood pressure and cardiovascular disease, including heart attack, is lead. So what's our biggest source of lead? It's not lead paint. It's not toddlers picking paint off the wall like it was when we were kids. It's actually gunshot wounds. And that's plenty of literature, totally not recognized, that leaving residual bullet fragments in a patient can actually increase their blood pressure as well as increasing their cardiovascular events. So if you just Google that, people would see that. And people will see the bullet fragments on an x-ray and say, oh, there's bullet fragments. No, that actually has cardiovascular meaning, totally unrecognized. Time? Okay. All right. Thank you very much.